Okay, great talk. Thank you so much. Our next speaker is Dr. Victoria Chung. She's an assistant professor in the Department of Internal Medicine at UT Southwestern in Dallas. She specializes in hematology and medical oncology with a focus on GI cancers and neuroendocrine cancers. She earned her medical degree in Alabama. She completed a residency in internal medicine and received advanced training in hematology oncology at Ochsner Medical Center in New Orleans, where she served as chief fellow. She is certified by the American Board of Internal Medicine. And she joined UT Southwestern faculty in 2024. Please help me welcome Dr. Chung.
Thank you. As he said, I did both my residency and fellowship here in New Orleans at Ochsner, so I was really happy to be invited back and to come back to New Orleans. It's been about a year and a half. Not a whole lot has changed as far as I can tell. There's still music in the streets. But anyways, thank you all for having me, and let's get started talking. I'm going to cover targeted treatments in colorectal cancer. Dr. Du taught me everything I know, so unintentionally, I kind of made the same exact talk as her, but in colorectal cancer. So we'll just see how that's a little bit different. I'm going to cover mostly the treatments that are targeted towards mutations that we find on NGS sequencing in colorectal cancer. So I'm not really going to be going through the first lines of treatment too much. But here's the NCCN guidelines for first-line treatment for advanced or metastatic colorectal cancer. I did put here in the red box, you can see that for BRAF V600E mutation positive, we do have encorafenib and cetuximab or panitumumab approved with FOLFOX in the guidelines. And then for second line, there's this whole area to the right here for biomarker-directed therapy. So I'll be going through all of these and talking about the trials that led to these approvals and what we expect from these treatments. First, to talk about the importance of biomarker testing and how much we need to make sure that we're doing that for our patients with colorectal cancer. About 20% of colorectal cancers are metastatic at diagnosis. It's the third most common cancer in both men and women, and it's the third or fourth most common cause of cancer-related death in men and women. The 5-year survival is about 15.6%, and we know that precision oncology improves outcomes in these patients. I found this study that was published just about 2 years ago that I thought was interesting. They collected data on 41,000 patients between 2010 and 2017. I recognize that was quite a bit of time ago, so things have changed. Only 28% of these patients actually got tested for KRAS, and only 43% were tested for MSI. The overall survival was improved for the patients that were tested, which does not surprise me. Patients treated in the community were less likely to have biomarker testing, and then also patients that were older, patients that had lower community education levels, rural residents, all of this was associated with lower odds of MSI and KRAS testing. I actually have a personal story for this. When I was a medical student rotating through my hematology and oncology rotation, this is about 2016, so that lets you know about when I graduated medical school. I saw a patient, she was somewhere around 45 years old, so very young, metastatic colon cancer. She was honestly in the process of dying. Her cancer had progressed really rapidly despite treatment, and she was going into liver failure. She was in terrible pain. What was really sad, though, was looking at her treatment history and seeing what had happened. She was being treated with FOLFOX, and I forget, it was either cetuximab or panitumumab, but she came to the oncologist that I was rotating with for a second opinion, and she had a KRAS mutation. And so that was just unfortunate to see that it wasn't being addressed. Actually, and real quick, I would like to give a shout out to 2 of the posters that I saw here that I think are really relevant to my talk. There was one by Dr. Abdullah that I would recommend everybody go see. It's a big purple poster. Those doctors are at LSU Shreveport. They found a high prevalence of POL mutant colorectal cancers in their Louisiana cohort, much higher than expected, and particularly in Black patients, which are often underrepresented in our studies. And another poster by Dr. Moutier, excuse me if I pronounced that wrong, at Tulane, looking specifically at MSI testing disparities and survival outcomes in Louisiana. And they found that only 65% of Louisiana patients being treated for colorectal cancer were tested for MSI status, which should be done for everybody. So still clearly a problem despite the fact that this data set is old. So at diagnosis, per NCCN guidelines, all patients with colorectal cancer should have their tumors tested for KRAS, NRAS, BRAF, MSI, HER2, and TRK, POL, and RET. There's many different companies that are offering NGS sequencing. Some places even have it in-house now. Something that can be pretty nice is some of these companies are also offering DPYD and UGT1A1 testing along with this next generation sequencing. So that's really handy for me. At UT Southwestern, we are still working on getting in-house DPYD. So for me, can be a really rapid way for me to get my answers about what genomic mutations these patients have, and then do I need to make dose reductions for their 5-FU, for their irinotecan, et cetera. And then for anybody that doesn't know, DPYD testing is now in the guidelines and is in the package insert for capecitabine. All right, so KRAS is probably our most relevant. Just like Dr. Du, I'm going to go in order from most prevalent to least prevalent. KRAS is found in about 30 to 40% of patients with colorectal cancer. It's involved in this pathway you can see here. When it's active, it initiates downstream signaling and it promotes cellular proliferation. I won't bore everybody with all the details. Mutations in the KRAS gene can stabilize the KRAS protein into its active state and therefore being constitutively active and activating cellular proliferation. Anyone that has a RAS mutation should not be treated with an anti-EGFR therapy, as in my personal story, so that's important to be checking for. KRAS inhibitors and degraders are also a really interesting target in a lot of clinical trials. I know a lot of people are very excited about that. Unfortunately, KRAS comes in many different flavors, and some of these are more druggable than others. KRAS G12C is only found in about 3 to 4 patients with colorectal cancer, but for this, we have approved drugs. You can use adagrasib and sotorasib to treat this mutation. You can also combine them with an anti-EGFR antibody to mitigate the EGFR reactivation that can happen when you're drugging the KRAS G12C. So there's 2 different studies just to be aware of. The Crystal-1 trial led to the approval of adagrasib plus cetuximab, and CodeBreak 300 led to the approval of sotorasib plus panitumumab. Other KRAS strategies, there's so much interest in this field, and we have clinical trials here at UT Southwestern. I'm sure they all do here in New Orleans as well, looking at pan-KRAS inhibitors, SOS1 inhibitors, KRAS G12D selective inhibitors and degraders, and then anti-RAS vaccines. And since this is so common in colon cancer, but also pancreatic cancer, it's definitely a very big area of interest. BRAF V600E is the new, not so new, but very exciting area right now in colorectal cancer. So this is found in about 8 to 12% of metastatic colorectal cancer. This does lead to a poorer prognosis and lower responses to chemotherapy than BRAF wild type disease. The Beacon trial established encorafenib and cetuximab as a viable second-line option. Encorafenib is a small molecule BRAF inhibitor, and then cetuximab, the EGFR inhibitor, helps to overcome BRAF reactivation. This was moved to the first line with the Breakwater trial by combining it with FOLFOX, as Dr. Du mentioned earlier. So here's the Breakwater trial. I think this is a really beautiful overall survival curve. You see the red line here is a combination of encorafenib plus cetuximab and FOLFOX, versus the yellow line is just encorafenib and cetuximab, which was previously approved in second line. And then blue is standard of care. And in this study, it truly was standard of care. It was FOLFOX or CAPOX or FOLFOXIRI plus or minus bevacizumab. We got an updated analysis of the Breakwater trial just a couple months ago at ASCO GI, basically proving that you can also combine this with FOLFIRI. That's really helpful for when we're seeing patients that already have some underlying neuropathy, or for some reason you really don't feel comfortable giving them oxaliplatin. This is also a reasonable first-line option. Right, next up is HER2. HER2 is found in about 3 to 5% of metastatic colorectal cancer, so not terribly common. A little bit more common if they're RAS wild type, up to 14%, depending on what study you look at. If someone has a HER2 mutation and then they're BRAF wild type, you can give them trastuzumab plus pertuzumab, lapatinib, or tucatinib in second line. And if they're HER2 3+, you can give them trastuzumab deruxtecan in the second line or later. Trastuzumab deruxtecan also notably still has activity in a lot of patients after they've already gotten a HER2-directed therapy. So the Mountaineer trial was a global phase 2 trial which enrolled patients with chemotherapy refractory HER2 positive RAS wild type metastatic colorectal cancer. It gave these patients tucatinib plus trastuzumab with a median progression-free survival of 8 months, overall survival of almost 2 years, and a duration of response of 15 months. There's also similar studies, the Heracles A study, which combined lapatinib and trastuzumab, and then the My Pathway Basket study combined pertuzumab and trastuzumab. Here is the waterfall plot for the Mountaineer final analysis. You can see, so the blue is partial response, and then green is complete response. So quite a few big responses in these tumors. Mountaineer 3 is an ongoing clinical trial looking at using chemotherapy plus tucatinib and trastuzumab up in the front line. Again, a lot of people looking at bringing these targeted agents into the front line in combination with chemotherapy. Destiny CRC01 was a multi-center open-label phase 2 trial, which gave patients trastuzumab deruxtecan in patients with HER2-positive metastatic colorectal cancer that had progressed after at least 2 lines of therapy. And notably, it allowed for patients that had previously gotten HER2-directed therapy. It's a really great time to be trastuzumab deruxtecan, as we know with the success in breast cancer. It's an antibody-drug conjugate, and it's an anti-HER2 monoclonal antibody, which is linked to a topoisomerase inhibitor payload. As Dr. Du mentioned in her talk, there's also this possibility of a bystander effect where it can kill nearby cells that don't have the HER2 antibody. Here's a waterfall plot for the Destiny CRC01 study. Again, beautiful waterfall plot, lots of response here. The orange little carrots that you see on some of these, those are all patients that had previously been treated with HER2-directed therapies. So you see even a complete response in one patient who had previously been treated with a HER2-directed therapy. NTRK fusions are very, very rare in colorectal cancer. I have had one in my 2 years as an attending physician, though, so you'll still see them. About 0.35% of metastatic colorectal cancers. It's only present in RAS-RAF wild-type colorectal cancers. And just of note, these inhibitors are only effective for NTRK fusions and not mutations, and that can be really easy to overlook. Also important to know that the IHC test for NTRK can be a false positive. I think it was in up to 20% of cases. So it's really important to be confirming these with an NGS study. I'm going to be honest, I've never ordered an NTRK IHC anyways. With the wide availability of NGS sequencing, I just do that. All right, NTRK inhibitors. There are 3 that we have available: larotrectinib, entrectinib, and repotrectinib. I'm not going to spend a whole lot of time on these studies since Dr. Du actually already went over them. But Navigate was the study that led to the approval of larotrectinib with an overall response rate of 25% in the colorectal cancer cohort. Entrectinib was approved in an analysis of 3 separate phase 1 and 2 studies. Overall response rate in the whole population is 57%, and then colorectal cancer patients, about a quarter of those patients had a response. The Trident-1 trial led to the approval of repotrectinib. These patients could have been pre-treated with larotrectinib or entrectinib, so that's important to note. PFS of 56% at 12 months in the TKI naive patients, and then 22% in those that had been pre-treated. All right, next up is the POL mutation, which, as we saw in one of our posters here, is maybe more prevalent in Louisiana, maybe more prevalent in the Black population than we had thought previously. POL mutations result in a loss of proofreading function. They can be found in proofreading-associated polyposis when it's germline. Somatic mutations are present in about 1 to 2% of colorectal cancers. They can cause a hypermutated phenotype, and so if you have a patient that has a POL1 mutation with the hypermutated phenotype, they should be treated as if they were an MSI-high colorectal cancer. So these have a very favorable prognosis. It's really important not to miss this one. RET fusion's very uncommon in colorectal cancer, less than 1%. The fusions activate the RET pathway. It's more prevalent in older patients and in right-sided tumors, and it has a worse prognosis. Per the libretto trial, you can treat these patients with selpercatinib, with an overall response rate of about 20% in the colorectal subgroup of the study. We have other targets under investigation, the PIK3 pathway, PIK3 mutations, and also MET. And another targeted treatment that I'm really looking forward to is zanzalintinib. Now, this isn't approved yet, but the Stellar 303 trial compared patients with chemo-refractory colorectal cancer and randomized them to get zanzalintinib, which is a multi-target TKI, plus atezolizumab versus regorafenib in refractory colorectal cancer. So, immunotherapy historically has not really worked very well in colorectal cancers, but the thought is that zanzalintinib targets these TAM family receptors and maybe allows for less of this negative immune regulation and allows them to be more sensitive to immunotherapy. So that's hence why they combine it with atezolizumab. This is the overall survival curve. As you can see, it outperformed regorafenib. Anybody who's prescribed regorafenib is very excited to give something before regorafenib. And this is under FDA review right now. So we talked about repeat testing earlier. Significant molecular changes are not really all that likely after just cytotoxic chemotherapy, but if you're giving somebody targeted treatments, the mutational profile can change. So I would definitely consider retesting. And I think that this is a really interesting graphic that I found. Looking at the y-axis is median progression-free survival, and the x-axis is objective response rate. The size of the circle represents how many of the patients were evaluated. As you can see, the immunotherapies are the sort of the pale blue circles. I mean, they have a great objective response rate and progression-free survival. I think none of us are terribly surprised by that, but it shows how important it is to make sure that we're identifying MSI high tumors when they're present. You can also see the HER2 targeted drugs do quite well. Those are the dark blue ones. They're definitely on the higher end for objective response rate. And then EGFR and BRAF mutation or targeting drugs are in the middle with orange. NTRK, I wish, did a little bit better, but it's still really important to find those when they exist because it's another good treatment option to have in the bag. So take-home points is I send NGS testing for all patients at the diagnosis of metastatic colorectal cancer. To be honest, I think we could even scratch out metastatic colorectal cancer. I think we, especially with the approval of using daily aspirin after treatment for colorectal cancers that have PIK3 mutations, I think you can justify in sending it in pretty much anybody. The rare mutations are rare. We keep saying, oh, it's less than 1% or it's less than 2%, but that compounds. When we're seeing all of these patients, you're going to find these mutations, and you'll never find them if you don't look for them. Consider clinical trial enrollment where available. We're lucky or everyone here is lucky to live near some really great cancer centers that have lots of ongoing clinical trials. Consider retesting after targeted treatments. And reevaluate the treatment algorithm at time of progression. New treatments are coming along every single day. I only graduated fellowship a couple years ago, and I'm still having to learn new treatments every single day. I didn't put that in there, but thank you.
I have a question.
Yes.
Like, can you tell us how you're doing the MSI and MMR testing? Is it all in-house IHC or MMR?
Yeah, so at UT Southwestern, MMR is all done in-house. That is, I would say about 95% of the time is reflexed. And so I already have that by the time I see the patient. It's in-house IHC.
That's what I'm thinking. We're doing the same thing like American testing for all colorectal cancer diagnosis and Oshner. But if we think that there may be, I don't know, like 2% to 5% of patients with poly mutation, then we're potentially, unless there is that disease, of course, we do NGS and all things, and it's like high. But if we don't have that disease, then anywhere from stage 1 to stage 3, we are not picking that up, right? I think right now, because like we need to consider, do they need an aspirin? Because if there's the mutation, we are sending all resected to NGS testing. We may be able to pick up one outside, but I wonder if we miss the 5% of patients, like they actually did not be in stage 2, they actually did not be adjuvant treatment because they have, say, MSI high, but because of poly mutation.
Yeah, I think that's a good point. We've at parts of, I work at UT Southwestern, but I also cover Parkland Hospital, which is kind of UT and kind of not. We've been working with the surgeons to actually have them send NGS testing at diagnosis for all colorectal cancer patients before they refer them to us, which is in process, but I'm hoping that'll help. Yeah.
That was my question. So who do you prefer send that should be simple diagnosis? You said, you mentioned retesting, if they have progression or, so who
So I would never be mad at a surgeon who sent a patient with stage 2 or 3 colorectal cancer who already had NGS, DPYD, and UGT1A1 testing to my doorstep. That would make me very happy. If I have all that information, exactly, I can get somebody started on the treatment that they need to be on.
It's now more pointed because you don't have to say, I think I'm going to do this, but I'm going to get your NGS and I'm going to see what we're going to do. It's already done.
Exactly. And I don't know how it is with everyone else, but for me, I have my long block with a patient the very first time I see them. And for subsequent visits, that's a much shorter visit time that I have to spend with them. I'd much rather have that long conversation about how I expect treatment to go, all of the drugs you're getting up front.
I think in the past, like, we only send for stage 4, right? Because within stage 4, like, we need to send it, the insurance should cover it. But for non-metastatic stage 1 through stage 3, we don't send it, like, who's going to pay for that, right? But right now, we have to, like, over the past 1 year, we know that they have P3C mutation, resected colorectal cancer, we need to give them aspirin. So I think right now, the initiative should be, we should send all colorectal cancer patients.
And but to your point, insurance will cover it?
I have not had a problem with it yet, but
Even in the 1 through 3s?
not yet. But
They will offer like patients.
We're talking about colon cancer or biliary tract cancer?
Colon.
But I think with the recommendation for aspirin with PIK3 mutations, you don't know unless you look, so you have to send
And
it.
there's no commercial P3C.
Yeah.
You just have to go through NGS.
Okay.
Any questions? All right, we're ready to go.